One. Believe it? Okay. All right, today we're going to cover three things. We're going to start off with rickettsial disease this morning. Okay, so rickettsial disease are a group of bacterial infections caused by various species of bacteria, okay, that belong to the genus Rickettsia. Okay. Real simple, not very difficult. Okay. We're going to try to keep this one easy for you. This one is spread by infected ticks, fleas, lice, and mites. Infected ticks, fleas, lice, and mites. Right? It's an acute febrile illness that occurs all over the world. And here's the nice thing about rickettsial diseases. You only need to know one drug. Doxy takes care of all of these. Doxycycline takes care of all of these. You don't have to remember any other meds, and we've already been covering some of the other ones, okay? Now, rickettsial disease is a little bit weird, okay? It's got its own little class for a reason, all right? The reason why it has its own little class is because sometimes it acts like a little bacteria, right? Where it's got cell walls and it's susceptible to antibiotics, i.e. the doxy, okay? But then it also kind of sort of acts like a virus where it has to live inside of a host cell in order to replicate, okay? Which is more like a viral infection. Transmission is through arthropod. They are the vectors for this thing. All right. Symptomatology is more viral bacterial. It's got a fever, it's got a rash. Okay, nothing different than anything else. It'll have some systemic symptoms, okay? Like viral infection. Now, what I need you to know off of this slide, if you look all the way at the bottom, okay, it's got usually are transmitted to humans by arthropods except for Q fever. Okay? Q fever is added on here just because it's similar and it used to be put under rickettsial diseases. Back in 2017, Q fever came off of the rickettsial family and went on to its own Legionella family. Okay? But Q fever has rickettsial-like illness, so we just kind of cram it under rickettsial disease, but it's the only one that's a little different. This one, it's inhaled, okay, versus the arthropod infections that you can get from the standard rickettsial diseases. So this one's inhaled. It is Coxella burnetii. And it's usually inhaled from bird fluids, feces, urine, or milk from infected animals, which are usually cattle, sheep, or goats. And those are the things that we would normally see when we go out, right? So think about your veterinarians that go out and deal with these kind of animals. Think about your civil affair folks that go out to underdeveloped countries and deal with these kind of animals. So keep that in mind as we move forward with some of this. Okay. How do they multiply? How does this happen? This is kind of no different than some of the other ones. The only difference here is that when the arthropod bites you, or the infected feces from lice or fleas get onto your body, you scratch it in, or you touch it and you touch it on the coastal surface of your body, like your mouth or your eyes, you can spread it to yourself. But in the area where it penetrates or it inoculates, right, where the flea or the lice bites you to feed, right, that's kind of where it propagates initially. Okay, so you may get like a little tingly feeling there, okay, almost like a cold sore popping up, but that's generally where you hit that feeling. And then it ends up spreading to your blood vessels. It likes the endothelial cells of your blood vessels, just like some of the other ones. So this does have a hemorrhagic component to it. So you will see some petechiae with this stuff. One of the more outstanding things that you'll find with this outside of petechiae is that some of that petechiae may become eschar-like. So you get black crusts on the outside of your body, particularly where the inoculation site occurred. Right? So that's kind of what this thing looks like, and that's what this thing does. And there it tells you it likes the skin and the adrenals, most common, but then it also spreads, or can spread to your central nervous system, your liver, and or your heart. All right, and those are big ones. All right, there, treatment, doxy, treatment, doxy, all of them, right? Path, we just talked about it. It likes the endothelial lining of your vessels, right? Very similar to some of the other ones that we've already spoken about. That zoonotic traits, because it's done through an arthropod, minus your acute fever. You're going to get some rash. The diagnosis is usually serology, PCR, or diagnostic. Okay? By looking at the patient and getting that HPI, you can already tell what some of this stuff is, especially if they have history of tick bite. Okay? So the first one we're going to talk about is the louse-borne, lice. This is body lice. The disease is caused by Rickettsia prowazekii, but the lice is the pediculus humanus. That's the one that lives on your body, right? Does it live on your body? No, it goes and feeds on your body, and then it hangs out on your clothes, on your bed sheets, and everything else until it goes or it comes back to feed on your body. We're going to talk about two types. Okay, we're going to talk about Rickettsia prowazekii, and we're going to talk about Rickettsia typhi. Here you can see that it's all over the place, Europe, Asia, Africa. Okay? I need you to remember, especially in Ethiopia and Nigeria, because I think that's where I put you for this scenario. All right? And there it tells you most of the cases in the last 2 decades have occurred in those areas. It's the most common, it's going to be important. Associated with overcrowding. Remember, these guys don't jump, these guys don't fly. If you guys share stuff, if you guys bump into each other, right, on the streets, at work, in refugee camps, which is what happens with a lot of these places overseas, it tends to spread really easily. All right, so remember those crowded places too. And there at the bottom it says resistant to doxy in Thailand, so consider azithromycin. Remember, depending upon what part of the world or where you're working, some things may be resistant to the specific man that you're supposed to use. Okay? Just keep that in mind, because this is prevalent worldwide. It's kind of sort of what they look like. Okay, so here's your signs and symptoms. Abrupt onset, 1 to 2 weeks following the exposure. 1 to 2 weeks following the exposure. Fever, I highlight intractable headache. I highlight that rash, day 4 to 7. Okay. Trunk to extremities. These guys are extremely important to know how the rash breaks out, because you're going to compare it to that RMSF, is Rocky Mountain Spotted Fever. Okay, so with the louse-borne, it's going to be trunk to arms and legs and head. Okay, that's where it's going to start, and then it goes out. With Rocky Mountain Spotted Fever, on the other hand, it's going to start on the wrists and the ankles, and then it's going to work its way up. Rocky Mountain Fever also does not spare the palms and soles. Louse rash does not spare the palms and soles. Okay? So it is an easy way to remember the difference. It'll start off as a macule, become a maculopapule, then it'll become petechiae. Depending on the severity that it is. Okay? Louse-borne typhus is worse than our typhi. Okay? This one is caused by lice. The other one that we're going to talk about is caused by a flea. Right? So this one is the worst of the two. Now, if you can get doxy on board sooner rather than later with this disease, you'll have a much better outcome. If you wait, okay, and this is the problem with ID, a lot of it. If you wait, it's gonna get worse, and your outcome not only will be delayed, but you may have a more severe outcome. All of these will be treated, whether they're mild or not mild, severe or not severe. All of these will be treated. The main reason why we treat all of these is because this thing likes to spread to other places. One of the places, right, we talked about at the very beginning was the heart, and we do not want it to get to the heart. all of them will be treated. This is kind of what it looks like. It's not a great picture, right? You can see a bunch of petechiae. You can see the petechiae over here. See all the petechiae out here already. There's a bunch of macules and papules. Popped up. Now, here are some other issues that you may have. Okay? This is the main reason why we treat all these complications that you're looking at. You see that hand has gangrene. That is one of those complications, right? This thing causes vasculitis, just like some of the other things that we talked about, where it messes up a lot of the small vessels in your hands, right? So when those things get blocked up, and you don't get circulation going there, it's going to cause you these things. So everyone gets treated because we want to try to avoid all of these complications. Right. Now, this is the only one that has Brill-Zissner disease. Okay. This is the only one that has that. Right. And the only thing Brill-Zissner is just there was two guys, two docs, one Brill, one Zissner. Okay. They discovered this thing. All this means is that this thing can go into a dormant phase and it can pop back out years. If you look at the resividating late phase there, it can be 10 to 20 years later down the road. Okay? What's not well understood is how do these guys kind of live in the spinal marrow, the lymphoid tissue, for years without detection? Okay, that's kind of the part that we're still trying to figure out. But what happens is you get treated for it, you think you're good, you get better, and then years down the road, the stuff pops back up. Right? And the assumption is that the dormant aspect has reawakened because your immune system has gone down enough that it pops right back up. This is the only one that has this. None of the other ones that we will talk about has a latent or dormant stage. Okay? Louse is the only one that has this. The next one that we're going to talk about is murine typhus. This one is caused by a flea. Okay, whether it be a flea bite or it's fecal matter. When you scratch yourself into a or you break your skin with the fecal matter, or you touch the fecal matter and you touch your eyes or your mouth and spread it to your mucous area, is how you end up getting this. Okay? So differences between the first two would be lice is one, flea is the other. Now the nice thing about the flea, murine typhus, or what Rickettsia typhi, is that it's milder than the first one. Okay. It's nice thing. It's milder than the first one. The symptoms are pretty close. They're very similar. Okay? But it's mild. That's the nice thing about this. Okay. Can they be self-limiting? They can. But again, due to the possible complications for both of these, right? Because this one can have the same complications the other one can. We just go ahead and treat across the board. All right. Now, the other thing with this one is that if you crush that flea, its remains are infected. So if you crush it and you get it into your skin, you can spread it to yourself. Okay? Now, I need you to remember large cities, often coastal regions, homeless population. Okay? These fleas live on rats. Okay? A lot of times people have rats as pets. Okay? A homeless person has a rat as a pet, and I bring them into the emergency room and they tell you that they want their pet rat back. That should be a clue to tell you that we're talking about murine typhus. Okay? You can see where some of the outbreaks are: Southern California, Houston, Texas, and Austin, Texas. Houston, Texas, and Austin, Texas. That's where we're at. Okay, so this is very common. All right. Death for Rickettsia disease for murine typhus is very low. This one is maybe 1%. Not that bad, but the complications are bad. So we treat anyway. With the first one, Prolactin, death rate 60 to 70% if you don't treat. Okay? Huge difference in that. This is also worldwide distribution. But here's our little Texas map. So thank you, Public Health, right? They kind of track all this stuff for us and let us know where all this stuff is happening. Right? So here's a whole bunch of places along the southeastern aspect of Texas, or southern aspect of Texas that has this. So if you're going to go work down in those areas, you know that urine typhus is in your AO. Okay. So similar to last one, milder and shorter, fever is less pronounced, headaches less severe, rash is less extreme. Okay. So really saying to you, this one does not have a Brill-Zisner, this one does not have a dormant or latent phase. There's another big difference between this one and the other. Okay. Incubation period usually 1 to 2 weeks. Okay. Pretty similar to the other one. Okay. Once you start giving doxy to this patient, within a couple of days, he's already going to start getting better. Okay. So a big difference between this guy and the other guy. But the symptoms, depending upon when you catch it, may last quite a bit. All right. So the next thing we're going to talk about is Rocky Mountain spotted fever. Rickettsia rickettsii. Tick, wood tick, dog tick. Okay, 2 specific ticks. The wood tick is generally in the western U.S. and the dog tick is generally in the eastern U.S. for Rocky Mountain spotted fever. This thing was originally found a long, long time ago when the settlers were moving out west. They initially called it Rocky Mountain spotted fever because they only found it initially in the Rocky Mountain area. And as its name states, you end up getting spots. Those spots that we're talking about are petechial spots. Right? As we mentioned, this thing likes the endothelial cells, causes vascular damage, and you end up getting some petechiae. In this case, your whole body starts looking like you got a whole bunch of little petechiae. So they initially called it Rocky Mountain spotted fever, but now we know this is a disease of the Western Hemisphere. What does that mean? What that means is that you don't usually see it overseas. You usually see it in Canada, North America, South America, Central America, Latin America. Usually you only see it on our side of the world. Okay, that's what that is. Generally spring to fall, most common for this thing. Right? Main reason why it's most common for this thing is because when your larvae and your nymphs of your ticks are born, those two specifically are getting infected. Right? So these things aren't born infected. They have to go bite something that's infected, get the infection, and then they carry it around in their little bodies. And when they come and bite you, they regurgitate the infection. That's how you get it into your body. Okay, those two, the larvae and the nymphs, are more apt at spreading the disease than the adult ones. The adult ones can spread it as well, but it's just the babies are more dangerous. Now in the southern states, remember the weather's a lot more temperate, so that stuff usually happens sporadically throughout the year in the southern states. Okay, here's a whole bunch of places where it happens: the Atlantic in the west, south central, increasing along the U.S.-Mexican border in Arizona, California. So that bottom piece is just a little case study that they did. But as you can see, it's a whole bunch of places within the United States that it's occurring. Right? Here's your map. Or you can see the most common. So the deep purple ones are the most common. So if you're going to work in these areas, you'll realize that Rocky Mountain spotted fever is a lot more common in those locations. Okay. So I need you to take a look at this little graph. I thought this little graph was actually extremely telling and extremely important. Right? So look, you have the little kids, right? They are the least affected, right? The most affected are the older folks. Okay? In this case, I would go ahead and say 50 and older. usually the highest prevalence, right? Not a big deal. We understand the older folks are probably more. But here's the problem. When you look at the fatality rate, look at the little kids. Okay? 0 through 9 have the highest fatality rate for Rocky Mountain spotted fever when compared to the 50 to 70-year-olds. Okay? So we, as adults, can probably handle this. Little kids probably cannot. So we need to make sure that if we assume or think little kids have this, we need to make sure that we're aggressive and start treatment immediately. Okay, Rocky Mountain spotted fever signs. Here you have some gastrointestinal signs, early stage skin necrosis, right? If we're talking petechiae, we're talking eschar. At some point, if it continues on, it's going to start necrosing at the skin. Okay? This thing can also spread to the heart. Okay, arrhythmias, just the cardiac failure. Right? Atelectasis. That's the rupture of one side of your lung, or one lobe of your lung. Okay, retinal disease. So we want to try to avoid this stuff if we can. Okay, with Rocky Mountain spotted disease, Rocky Mountain spotted fever, extremely important to get it on board as soon as possible, your antibiotics. I need you to know this slide. This slide's going to be on your test. There's 4 particular stages or time periods that you really need to be aware of when you're trying to diagnose this thing. The average incubation period could be anywhere between 2 to 14 days, so average is about 7 days, right? So if you look at days 1 through 2, abrupt onset of high fever and headaches. Okay, great. That's really not telling me much. It's kind of similar to everything else, right? But then days 2 through 4 should be somewhat of a giveaway that you have Rocky Mountain spotted fever, because it looks, you have faint rash that starts on your wrist and ankles. So understand that the rash for Rocky Mountain spotted fever starts on your wrist and ankles. Then it works its way centrally towards your torso, which is completely opposite from louse. Right? That is a way to separate it. When you start seeing a rash on the wrist and ankles, if somebody tells you one of your first differentials should be Rocky Mountain spotted fever, right? Then you base that against your HPI that you get from the patient. And 2 and 2 together can give you a diagnosis for this. Right? From there, it spreads centrally. We have abdominal pain, nausea, vomiting, cough, malaise, calf tenderness, periorbital and peripheral edema. Okay? So, between days 1 and 4 is when you need to realize that you have this disease process. You want to try to get doxy on board no later than day 5. Okay? That will give you your best outcome for this patient. If you give it to them after the fact, if you're like, well, I want to wait, I want to see, so days 5 through 7, progresses, fever continues to be high, right? 104. Worsening of respiratory status, worsening of abdominal pain, rash becomes petechial. That's when it starts becoming spotted. That's when you get the namesake. And then it starts involving the palms and soles. This one does not spare your palms and soles. Another way to tell the difference. Okay? If you wait till after that time frame, your outcome, not only will it be delayed, but you're going to end up having complications because you waited and this thing has continued to progress inside the body. Okay? The best bet would be to get it on before the 5th day for doxy. And on day 7 through 9, the rash collates, forms purpura. Necrosis of digits can lead to the gangrene, the picture that we saw. You can end up in septic shock, you can have myocarditis, cardiac arrhythmias. All these complications can pop up if you don't get the doxy on board sooner rather than later. Right. And these are a lot of the same complications that you just saw for the other 2. Okay. Complications are very similar for all of these rickettsial diseases, which is why we need to get medications on board sooner rather than later, and we just go ahead and treat everyone with rickettsial disease, regardless of whether it's mild or severe or moderate. This is what your petechiae stuff will look like all over your body. Why they came up with spotted feet. Okay. Here's a petechiae on your hands. Over here, it's already looking like it's starting to coalesce with a bunch of other petechiae. Okay. This guy's got it all over his torso. This is what that black eschar would look like if you continue to let it go without treatment. And remember, whenever we have necrosis, it's hard for any antibiotics that we give anyone to penetrate those areas. This stuff usually happens between days 9 and 7 through 9. There's some gangrene fingers. Okay. Vasculitis can also cause thrombosis, which can also lead to blockages of the smaller vessels, right, causing endothelial damage, leakage. Right. This is happening in the smaller vessels that are very visual. You're not necessarily seeing all the other smaller vessels in the brain or in the eyes, but this may also be happening to you. So what are you going to do? You can do CBC count. You're going to have thrombocytopenia. You're going to have hyponatremia, right? Because the vessels are leaking. Right? So it's leaking out sodium. Elevated transaminases, because this thing is attacking your liver and a whole bunch of other organs. So when you do your LFTs, your AST will probably be higher than your ALT. And then you have lactic acid increase, creatine increase, and your muscles are getting beat up. Like blood cells may be elevated because they can see all the infection that's occurring. So you've got a whole bunch of things that you can find on your labs. Best thing to do would be a skin biopsy. Send that off, and they'll tell you exactly what it is. You can cross off their serologic PCR. We're not going to do a serologic PCR here. The PCR is going to be used against that skin biopsy that we're receiving. Okay? In order for you to know that this is what it is. If you're going to do other lab work, your best lab work would be an IFA or an ELISA, and you should really do an acute and a convalescent, and that will definitely tell you whether you have this stuff or not. Okay? And there at the bottom it says treatment, DOSI is your drug of choice. Most effective is started within 5 days of symptoms. Okay? Questions? No? Okay. All right, the next one we're going to talk about is Q fever. This thing also occurs worldwide. Coxiella brunetti, right? No longer part of the Rickettsial family, now it's part of the Legionella family. All right, at least taxonomy-wise, microbiology. So if you start talking to Major Hulsberg about this, she'll flip out on you and tell you that's not where it belongs. So be careful with that. Talk to her about this stuff. Primary reservoir for these things are usually sheep, cattle, goats. We usually inhale infected stuff. Stool, birth fluids is one of the #1 things. If you handle placenta from infected animals, it's another way that we can get this stuff. This thing is extremely infectious. This thing is extremely infectious. It takes less than 10 of those little vurons, or those little organisms, to be inhaled in order for you to get this. Okay? So remember, whenever we talk about infectious, highly infectious, respiratory type stuff, we usually don't do cultures unless we tell people that this is what we need to do. In this case, this will be a bio level 4. It's got to go to the CDC for them to do this stuff. Okay? Remember, it's inhaled, so it's going to go to your lungs, right? And this thing, once it goes to your lungs, your macrophages are going to try to attack it. Right? Your macrophages in your lungs. Right? The thing with that is, it's going to do the same thing that it kind of sort of does to TB. Right? It's trying to fight, it's trying to kill it, but eventually it'll end up growing granulomas around it. If it does get out of your lungs, which eventually it does when it becomes systemic, it forms granulomas in different parts of your body. It can form a granuloma in your liver, causing hepatitis, which is the example that they give you down there at the bottom, because it likes particular epithelial organs, so that would be your liver and your spleen. So you may be able to see some granulomatous changes in some of these organs once you get infected. Okay. So here's a whole bunch of common places that you can find it: slaughterhouses, research facilities, livestock farming. There, it's pretty important. Military think to deploy veterinarians and civil affairs teams. Right? You guys would know if they belong to you what kind of things they're doing. Any contact with any fluids of any of the affected animals, particularly birthing fluids. Okay? That would include urine and feces. Sometimes that's what happens when they birth. Can also get you infected. And then obviously inhalation of the bacteria is usually causes the problem. Here's a whole bunch of fevers, a whole bunch of signs and symptoms. Fever, intractable headache, I'm going to highlight those. So there's no rash with T fever. Okay, no rash. So nice difference from the other three that we talked about. This one has no rash. They'll have hepatosplenomegaly, right? It likes to render reticular epithelial cells, so that would be your liver and your spleen. Hence the hepatosplenomegaly. There you can look at some of the radiographs. You have some multiple segmental opacities, right? So you're going to have some pleural effusion. Right? That just means that you're going to have some abnormal accumulation of fluid in your lungs, right? Remember, those things go into your lungs, they start eating away at your tissue, your body's trying to form granulomas, but given enough time, it may eat away, so it may cause some fluid buildup in your lungs. Hence the pleural effusion, right? And have that local consolidation. So when you take a look at that chest X-ray, instead of it looking black, it's going to look white, right? And then ultimately you have that linear atelectasis, at which point it could be one lump, it could be a lobe of your lung, it can cause it to collapse. So it'll be very notable when you do that chest X-ray. All right, that's signs and symptoms for acute fever. We're really going to have non-specific laboratory findings. You may have some leukopenia, may have thrombocytopenia. But hyponatremia in this case is triggered because it triggers an anti-diuretic hormone, ADH. You guys remember that? I don't think you guys have done endo yet. But ADH helps the body retain water. For some reason, it triggers it once it goes into your body. And as it triggers it, your body retains it. That's the swelling of your body. You end up having increased water, decreasing your sodium inside your body, and ending up with hyponatremia. You can use serology here. That one would be the acute and convalescent, either EIA or ELISA for your serology. This one, again, rickettsial-like disease, in which case, whenever you do this stuff, sometimes you may have cross-reactivity with some of the other rickettsial diseases, which is kind of hard, which is why they say some of the serology stuff you may have some cross-reactivity with some of the other rickettsial issues. But you can do your IUA, IFA, or ELISA. You can do PCR. PCR is not available everywhere for this. Generally, the CDC controls the PCR for this. There's very few places that actually have PCR for acute fever, but you can get those results back within a day, less than a day, if you do the PCR stuff. Some places have a Q panel, Q fever panel. Okay? In that Q fever panel, it'll do EIA and ELISA for you together, and it'll give you your answer. And then because this is highly infectious, usually it'll do culture for this kind of stuff. All right. Here's a whole bunch more facts. Rocky Mountain spotted fever without therapy is approximately 25%. With therapy, 5 to 10%. Okay. The sooner you get on board, the better off you'll be. Louse under 12 is uncommon, but 67% older than 50 years of age. This is not going to be on the test. Anybody have any questions? No? All right. Moving on. Lyme disease is next, right?
Sir.
Yes? All right. Anybody have Lyme disease in here? No? Really common in the northeast of the U.S. Here we'll see that it's not just the northeast of the U.S., right? This is Sporoky, Borrelia burgdorferi. Always good to know all the scientific names for this. This is usually spread by a deer tick. Okay. The family of the deer tick belongs to is the Ioxodes family. Because we're going to have two different ticks that are going to cause the same problem, one on the East Coast and one on the West Coast. Right. The only reason why we found this out, because in the mid-70s there was a cluster of children and adults in Lyme, Connecticut. Anybody from Connecticut? No? Yes? You know where Lyme, Connecticut is? No? Southwest? Okay. Well, back in the mid-70s, they had a cluster of children with Lyme disease symptoms, arthritic type symptoms, which led folks to go there, and then they realized that this was a tick-borne disease, in which case they called it Lyme's. Okay. And there you can see common in the United States, Maine to north, Maryland to Maine, Wisconsin and Minnesota, and there's a smaller focus over in Northern California. Love this picture. Okay, this is a dark field microscopy photomicrograph of the spirochete Borrelia burgdorferi. So, you know, it's not a great picture because it's so blown up. Like all these little things are the spirochetes. Okay, that's a spirochete, that's a spirochete. Okay, these are all the little spirochetes that are causing the problem. Right. So liposurgeon Lyme disease, here they're just basically telling you we're going out into their area, we're not protecting ourselves in their area. There's been an explosion of deer, so the deer ticks are popping out even more. So remember, protection is key for infectious disease. So make sure people are actually going out there. They protect themselves, or they wear spray so that they don't actually get Lyme disease. Spring through fall, same deal with these little guys. The nymphs are the ones that really have the most spreading factor. Okay, this cute little guy here is what we call the white-footed mouse. This is the primary reservoir for these little ticks. Okay. These guys carry the infection. The ticks feed on these guys, and the ticks get it from these guys. As their nymphs and larvae, and as they continue to grow, they already get it into their gut. So when they do bite us at that same time period, we end up getting it. Okay. Here's a deer. We have the adults usually feed more so on the deer. The adults don't spread it as easily as the kids, to be the larvae and the nymph, do. But they still have the ability to spread it. There's your map across the U.S. Right? So here you can see if you guys work in the upper northeast of the U.S., up in this little region here, okay, Lyme is common. Lyme is common. Who cares? Well, if you have people that are showing up with, arthritic symptoms, our age, why would your knee be hurting and have arthritic type symptoms? Well, this might be it. That might be one. The other one might be that those people may already be seropositive for some of this stuff. Now, even though you become seropositive, you do not get lifelong immunity to this stuff. You can get it again and again and again. So keep that in mind. Okay. So over in the West Coast, over where you see the little population gaps there in Northern California, okay, the tick is the western black-legged tick. That's the one that causes Lyme's over there, okay, versus the deer tick, which is what causes Lyme's in the upper northeast of the U.S. and the central area there of the U.S. Most common. Okay. Here's your path for your tick. Okay. So attach for 2 to 3 days. So here's key. magic number is generally anywhere between 36 to 48 hours. That thing needs to fight you for. It needs to be on you, fighting you for at least 36 to 48 hours is what the magic number is, in order for it to be able to spread its intestinal gut stuff into you and then possibly contaminate you. Which is why they say, hey, if you see one and you pull it right off, the likelihood of you acquiring Lyme disease is very, very minimal. Okay? As they say, minimum of 36 hours to 48 hours is what's required for that thing to be on you and feeding off of you. Okay? Now, it'll propagate, right, wherever it bites you, right? Wherever it got into your skin, it'll propagate within that area. It'll continue to grow in that area until it starts spreading outward. That's usually what it does. It likes the lymphatic system, so as it continues to propagate in that area, it will find its way to the lymphatic system and go to the rest of your body. Okay? So because it likes the lymphatic system, you should know from that spot that you are going to end up getting regional lymphadenopathy. Okay? And once it becomes systemic, you may end up getting more lymphadenopathy, but initially you'll have some regional lymphadenopathy. All right? Okay, so here it tells you your lymph stages, 85% in the springtime. Okay. These are the little guys that you will not see because they are so small when they're biting you and feeding on you. Okay? Vice the adults, which are a little bit larger, and you'll be able to see when they bite you. Okay? So here's some other thoughts about transmission. It needs to actually be attached to your body. It needs to feed off of your body. Here it says at least 24 hours, but if you look at book answers are generally 36 to 48. Right? We like to go with the lesser hours because at least you're a little bit safer with that time frame. Okay? Active during warm seasons, that's generally when they hatch, when they grow, right? When they're out and about. They don't fly, they just crawl. Right? You walk through tall grass, it just attaches onto your clothes or to your skin. Okay? You see a lot of that in the Northeast. They insert their mouth parts into your skin. This is how they feed. Okay? And they're slow feeders. That is the main reason why they need to be attached to you for a minimum time frame in order for it to actually spread the disease, because it's actually coming from your gut to their salivary glands, and then that is what gets into your body to get you infected. So this is kind of what they look like. These are all the eggs. Generally don't really see those much. Here's a baby nymph right here. You can barely see it, right? Here's a nymph right here. This is a male. Adult male, this is an adult female. So generally when they're like this, we don't even see them. Okay? Even at this stage, they're this small, we generally don't even see them. Yes, sir.
Are the babies still able to feed, like, and spread it?
Say that again?
Are the babies still able to feed and spread the disease, or?
Okay. So did everybody hear what he said? No. He asked the question, are babies able to spread the disease when they feed? Right?
Yes.
So the answer is yes, if they've already fed on something that has infected them. Okay? So just like all the other mosquito-related diseases or arthropod-related diseases, they have to bite something infected so that they can get infected, in which case they will pass it on. If they're newborn and have not bitten anything and gotten infected, hey, you can feed all day, you've got it. Okay? You're not going to get Lyme disease. But the concern is that we don't know that. Okay? We don't know. And that's where that cute little white-footed mouse comes into play, right? Small, those little babies usually get onto those mice, and that's usually where they get or contract the illness, and then they just pass it on. Here's two more. Huge. That's what we call an engorged tick. Okay? Don't rupture it. Do not rupture it. As much as you really tempted to want to pop it, don't pop it. Okay? Because that fluid, that blood, is also infective, and it'll get on your hands. If you have breaks in your hands and your fingers, it'll get into your skin, which you don't want. There's another gorged one. Here's frequency. So you're going to get a lot of false positive antibody tests. And you're going to get a lot of folks that are asymptomatic but have the seropositivity, right? So anybody who lives in those areas are going to be seropositive. Just because they may have had it, their body may have cleared it, no issues, no problem, right? So that's where it kind of comes into play, and it becomes a slight problem when you start doing some blood work on folks and like, oh yeah, you have it, but oh wait, you're asymptomatic, right? So then you probably don't have to worry about it, because if you're not showing any symptoms, you should be okay. It means your body's taking care of it. So it kind of gets a little dicey there. Right? Yeah, 5 to 10% of endemic people are positive. That's your seropositivity for the folks that usually live in those areas. Now, when you do some of these tests will cross-react with some other tests that we can do, like, for example, for syphilis, right? The syphilis is also a spirochete type disease, so it cross-reacts with that exam, which may also be a false positive. So just keep in mind, some of these with clients will cross-react with other spirochete type diseases and some other viral diseases as well, giving you a false sense of positive. You know, and you would initially think, oh yeah, you've been infected, now you're better, you're seropositive, you have immunity, or lifelong immunity, and that's not the right thought process. For these guys, you don't end up with immunity. Okay? You'll have some things that'll protect you if you do get some more, but it still won't wholeheartedly protect you against getting it again. The key for diagnosing Lyme's is the erythema migrans that occurs at the site of the bite infection. So wherever that thing hits you, generally you'll get what we call erythema migrans. Okay? And then erythema migrans usually looks like a little target lesion. Okay? Looks like a bullseye, or it may look like a cleared central clearing, which would be just the opposite inversion of the bullseye. It'll have the surrounding, but instead of a bullseye, it'll be clear. Okay? That is the general typical finding to denote that it's a Lyme disease infection. Right. So let's go ahead and take a break. They asked, when I checked, prions will not be on the test. And I didn't see any prion questions, so one less thing that you have to study, right?
Prions.
All right, so as we move forward, we got 3 possible things that can happen. The body can get this thing, it'll clear it, no issues, no problems, number 1. Number 3, your body can see, it'll cause an immune response, then your body will clear it, no issues, no problems. With both number 1 and number 3, you're still going to be seropositive, but no issues, no problems, no complications. Okay, your body did what it's supposed to do to care of it. Number 2, on the other hand, it's going to spread throughout the body, it's going to produce direct evasion. Once it becomes systemic, this is the one that we need to consider to take care of. All right? So these are the things that we look at. 3 stages: localized, disseminated, persistent. Okay? The localized, or the early stage of this thing, usually happens within days to weeks. Okay, after that tick bite. And the hallmark sign is erythema migrans. The hallmark sign is erythema migrans. Erythema migrans is that thing that looks like a bullseye, or an inverse bullseye where the central portion is clear. That will happen at the inoculation site. Okay? It'll happen where you got bit initially, As this thing goes on and becomes systemic, you may get different ones in different places, but initially, okay, early localized phase, this is going to happen where you got bit. Okay? If this thing continues to go on, you may end up having fever, fatigue, headaches, muscle joint aches, which are one of the more common things, and then you may end up getting those swollen lymph nodes that we talked about earlier. Right? If it gets to the disseminated phase, because it's not treated, then it's spread into the bloodstream and start affecting other places in your body, like those joints, causing Lyme arthritis. And it can spread to other places, like your central nervous system, causing you neurologic problems, to your face, causing you facial droop, Bell's palsy-like, cranial nerve 7, okay, most commonly affected with this thing. So, always want to treat this thing as soon as you can. Right? This thing can also lead to cardiac abnormalities if you let it go without treatment. So most definitely, if at all possible, let's treat. Okay, so usually 7 to 14 days after tick bite, on average. Okay. Key distinguishing hallmark is erythema migrans in 2/3 of patients. It's that here it says confluent patch of erythema enlarges over the area, may have central clearing. Okay. It looks like a target lesion. It looks like a target. You know what a target looks like that you shoot down range? That's what it looks like. Maybe inverse, may have central clearing. Okay. You're going to end up with fever, shiver, myalgia, arthritis, and lymphadenopathies. This is your hallmark feature of the first stage. It can look like this. All this area is the erythema area, and there's your target right here. That's met in the middle. All right. This may also be clear. Okay? So depending upon which one they get is what you're looking at. This one's already grown out, but this one has central clearing. It's another means of presentation. These are two confluent erythema migrans. Okay, here's one, here's a central for this one, and here's a central for this other one. And they're growing enough that they're growing into each other. Here's another one. Okay. We have quite a few different presentations of the erythema migrans there. Right. So fever, tendinopathy, we talked about that. Regional to generalized, conjunctivitis, meningitis. Meningitis just means you have meningeal-like symptoms, but they're not being caused by the meninges. So it's not meningitis. That's all that means. Okay. And then I need you to highlight that bottom part where it says cranial neuropathy, especially cranial nerve 7. This thing can affect cranial nerve 7. You remember cranial nerve 7 comes across the face, right? 3 different branches, branches B1, 2, and 3. Okay, if it does affect your face, and you end up with Bell's palsy, that is one of the giveaways. Understand that generally it is unilateral. Generally, in very rare instances will it be bilateral. Okay. So this is usually unilateral. Okay. So you should highlight that part. And if you do end up getting that Bell's palsy or cranial nerve 7 infection, then you should probably give them a tapered dose of steroids. That should hopefully knock down some of the problems. I need you to remember this slide because this one's also on. Okay. It causes cardiac problems, specifically heart blocks 1, 2, or 3. Okay. If it doesn't make it to your heart, you're going to end up with some cardiac abnormalities. This is extremely important because you want to take care of these cardiac things, right? Cardiac stuff is bad. Right? And if you do end up with some of these, here's some more of your symptoms: lightheadedness, palpitation, shortness of breath, and chest pain. Right? So understand that heart blocks 1, 2, or 3, third degree, may be a possibility. Okay, this young lady here has Bell's palsy. Right? If we look at the one on the left, okay, if we look at the one on the left, which side do you think is affected?
Left.
Her left or my left?
Her left.
Her left is effective, yes, you are correct, right? So what are we looking for when we look at those things, right? We look to see if we can get that eye to close. This one's already closing, this one is not, okay? You look at that corner of the mouth, it's going up, right? You tell her to smile, that's your neurologic exam. Puff out your cheek, smile, look at your forehead, close your eyes, right? So all this stuff that you're talking about now, right? So this is this right here, if you're never quite sure, if you see a nasolabial fold here, that is a very telling sign that yes, it's still good. Okay? So here there's no labial fold, this is not going up on that side, so the left side is the side that's affected. So months later, after inoculation, if this thing continues on, you may end up getting arthritis, which is a hallmark late sign of Lyme's. Okay? Bigger joints, most common, the knees. Okay? The knees most common. Here it tells you knees involved in 90% of cases. Now, this thing says rarely destructive. If you get doxy on board early enough, you can actually make this go away. Okay, so this, you don't usually say that about arthritis, but if you have Lyme's arthritis and you get it on board, you can make it go away. It'll like not have any more arthritic problems from Lyme's. But if you let it go on long enough, okay, eventually all the inflammation inside that joint will start tearing away, and some of the joint itself will start causing some destruction. But that's going to take a long time. In some cases where people have not done anything after having this, they say maybe it might be about 10 years down the road before it may go away on its own. The arthritic aspect of Lyme's disease. It's crazy, right? But it is a possibility. But if we always treat, let's treat. Okay? Now remember, this is already months down the road. So now when you're doing your HPI, you're like, hey, did you ever have like a target lesion with migraines? They may not remember. And the other aspect, especially if they're older and it is on a different part of their body that they may not see, they may not have even been aware that they had it or have gotten bitten by a tick. Okay, more arthritis type stuff. Initially, a whole bunch of your joints are going to hurt, right? Quality issues. As time goes on, it ends up becoming more mono. Right? So it ends up picking one of the joints, usually the knees, one of the bigger joints, and then it could be knee, ankle, wrist, and in frequency of how it affects the joint. With knee being the best or the most popular for Lyme's disease. 2/3 of patients' first episode occurs within 6 months of having the urothelial migraine. Remember, urothelial migraines on its own just disappears over the course of a couple of weeks and just goes away on its own, regardless of whether you do anything or not. Which is why when this stuff happens months or a year down the road, people won't remember this. So it usually resolves over a 10-year period. Do they really need to suffer in that means over 10-year time period? Not if we can take care of it, right? So we treat. Now, let's understand that there's also what we call post-treatment Lyme disease syndrome, PTLDS. This is very similar to what we have with COVID right now, where we have long COVID, right? You've been cured of the disease, you don't have it in your system anymore, but you're still having symptoms. So this has the same thing. Okay? The PTLDS, once you've been cured, you may still have those symptoms for a long period of time after the fact. Okay? It is a possibility of this. Okay? Here's some chronic manifestations, arthritis being one of them. So some patients still have that fatigue, that headache, that joint and muscle aches. Okay? Some may even have cognitive dysfunction or cognitive problems even after being successfully treated with the antibiotics. Okay? Which one those are, we don't know. Okay? Which one of those are, we do not know. But what we do know is that they may have some of these symptoms, but the infection has cleared their body. So when you do their stuff, you see no more infection. So we still don't understand how they're still having some of these post-treatment problems. So thoughts on pregnancy? Pregnant women should be treated. Now with doxy or tetracycline, generally we'll treat women with amoxicillin 500 milligrams. Okay? Amoxicillin is a category B, so it's known to be somewhat safe in animal studies, so we can get the pregnant women. That will be your alternate for doxy. Pregnant women can pass this in utero to the baby. Okay? Right now, as it stands, there has been no congenital defects known. Things can change. But there has been some possibilities of stillbirth and spontaneous abortions. Okay? Now here's your caveat. Okay? If a pregnant woman is already seropositive for Lyme and they're asymptomatic, you don't need to treat. If they've already been seropositive. If they're not seropositive and they get it, generally you'll treat. Alright? This right here, you don't need to know, it's not going to be on the test. Alright? All this is a case definition for us, providers, okay, to have a uniform criteria for telling public health that this is what we've got. So when we're looking at patients, right, diagnosis of urethral migraines or clinically compatible late manifestations of Lyme disease is what we'll report to public health so that they can track. That's all this is to let you know. This is the criteria that they need to use when we report, so that they can track stuff. Okay, labs and diagnostic procedures, most widely antibody detection tests. Generally what we use. Remember, there is still a window that these guys will not show up when you do your serology. Okay? These guys are a little bit slower to grow and develop. So instead of the 1 to 2, generally the 1 week, 2 week window that we have with standard stuff, this window will be about 2 to 4 weeks. So if you're doing things serology-wise earlier than that, you may get a negative result. Okay. So keep that in mind. The other thing with this is that because you have so many false positives and possible false negatives, that we do have a confirmatory test. And the confirmatory test that we usually use is Western blot. Okay. We've got another one, but generally we'll do EIA or IFA for titers. If that's positive, generally we'll do the Western blot for confirmation. Okay. You have an alternative method there. You can do step 1 twice. Okay. That is an alternative method both for checking and then for verifying. But then you also have your Dorothy, IgG, IgM, VLSE, OSPC. Okay. And what that is that VLSE, that VLSE is variable large protein E, and then the other one is outer surface protein C. Outer surface protein C. Okay. Those are very specific for Lyme disease. So when they do that test, they'll look for those specific proteins to verify that you do have. So those are your tests that you can do. It really depends upon where you work. Generally, most places have an SOP for specific policies that tell you how to look at these things. Remember, if you are further on and in the late disease, this person may have chest pain, shortness of breath. Okay, you can do some ECGs, right? Because you're looking for first, second, or third degree AV blocks. Which may be something that you find later on in the disease process, other than just joint arthritis. CBC is really not going to do much for you because it's not really going to be elevated. Your ESR, your urethral sedimentation, that should have rate at the end of that, will be elevated. This is an inflammatory process, so it'll be up. You can use it in conjunction with CRP, but generally ESR is good enough, especially if you're going to track it. If you do have joint swell it, you can always draw some fluid and send it off to the lab. I need you to know this slide. Okay? It's really important because it gives you all your therapies. Right? So here, if you got tick bite in the endemic area, or you have an engorged tick that they tell you they found, you treat it with doxy. If you have a tick bite not from an endemic area, right, not from the northeast, because you're in the south, and there are no deer ticks or western-legged ticks, then no therapy is required. Okay? If you do have erythema migrans, you treat with doxy. If you're pregnant, you're going to treat with amoxicillin. Okay? If you have carditis, you're going to treat with ceftriaxone and doxycycline. Okay? Facial nerve palsy, you're going to treat with doxycycline. You would probably add a steroid on top of that to knock down the inflammatory process. Okay? If you have meningitis, you'll proceed with ceftriaxone. If you have arthritis, you'll treat with doxy. Okay? Yes, sir.
Did you say or and for carditis?
I'm sorry, I can't hear you.
Is it one drug or two drugs for carditis?
It'll be 2 drugs. Question was, do you treat with 1 or 2, and then treat with 2 drugs for carditis? Any other questions? Okay. Prevention is key. I'm not gonna belabor that. You can avoid the ticks, wear long pants if you're gonna be roaming around the woods. Okay, wear long sleeves so that as you brush through the woods, while you're walking through the woods, stuff doesn't just get onto your arms. Okay. Most common places it likes is the groin, the axilla, and the hairline. So if you are checking someone for that, make sure you check the hairline. Okay, in the axilla areas, the groin areas, you can do on your own. Right. Pets can also transmit these things. They can also get Lyme, so you may want to check your pet. Come in the house, they can also release those little ticks and they can come and get onto you as well. Can use repellents. We used to have Lyme-Rex, which used to be a vaccine a long time ago. I believe in 2002 they took it off the market. Not just because not too many people were using it, but they were having some serious side effects and some efficacy of the vaccine, whether it was truly working right or not. So it came off the market. So we don't have any vaccine for any of this stuff. This is what the tick is. If you're not quite sure what to do, and take forceps, go as close to the skin, try to grab the tick head. Don't crush it, just pull it straight up off the skin. Okay, just keep the pressure on it because you want it to release its bite, and then you can just put it into a little baggie, and if you want, you can put it into alcohol and it's just will go. Okay, this lady's checking hairline on this other lady, make sure that she's not having any. This dude's putting his pants into his socks as he's walking through the woods versus the guys on the left. These are the more common areas for your pets if you do walking through wooded areas. Around the tail, right? In between the legs, between the toes. Around the collar seems to be a very common place for them to hook onto. So check around the neck and around the collar. Ears and eyes are the other 2 big places for the head. Anybody have any questions? All right. All right, rabies. This is basically a viral disease transmitted by the saliva of infected bats or certain animals. Could be raccoons, could be dogs, could be cats. Okay. Other animals can spread this stuff. Okay. But it does attack your central nervous system. That's what it likes. That's where it goes. Every place likes a specific home. This place likes a central nervous system. Okay. Understand, rabies is one of the oldest diseases we have. We have found rabies back since 23 BC. Mesopotamia, we've found rabies. We've found mummies with tuberculosis, HSV, and rabies. Okay, so rabies has been around for a long, long time. All right. Another aspect of rabies, okay, I found really interesting is the myth and the thought process of back in the day when, science was not a big thing, people would see things and they would freak out. So this one has a myth attached to it as part of what grew werewolf, the myth of the werewolf, because these guys were seen forming at the mouth, couldn't cross water, right, because they were scared. But this is one of the ones that led to the werewolf myth going up. And here's some facts and figures. Potential exposure is commonly overlooked, right? Little nips, little scratches, and you're messing around with some stray dogs or stray cats someplace, or trying to be friends with some crazy raccoon out in the woods, right? And they scratch you, nip you, bite you, or whatever. You're like, oh, okay, I'll be alright. Eventually, it can affect you if it does have what it is. This thing does happen all over the world. Okay? There are some countries that are more endemic than others. Africa, Asia, India, and South America can also be added on there. Big deals with these guys are that they have a lot of wild animals that roam in those areas. They have a lot of wild dogs that roam around in these areas. So the wild dogs are the number one worldwide. You can spread your rabies. So here you have bat rabies, third most reported type in recent years, but you have raccoons come to bats, top 3 in the US, in the US that can affect you. Terrestrial rabies, so you have your cats, number 1 domestic, okay? Inclusive by stray animals, but eastern coast, raccoons, Texas, Mexico border, skunk, coyotes, foxes, and dogs. So every part of the country has its specific animal that's going to be more common to spread the rabies. Okay? So, thing for you to know. Here is telling you it's worldwide. Internationally, the dog is the main vector for this. NHP is not human primates. Okay? So those are monkeys. Okay? Monkeys can spread rabies to us. Have you guys ever been to? Have you guys ever seen those Thailand Kofi monkey beach or temple pictures? Have you guys ever been there? Okay, so when you go up onto this beach, you got monkeys everywhere. Okay, you don't know if any of those monkeys have anything. So, when you're traveling, you still need to be careful of where you go and what you see and what you're interacting with. Okay? Non-human primates, these guys, can spread this stuff too. Okay? This is the temple. Right? These guys are all over. Right? So, just things to remember. Right? Because, like I said, part of our job is to be travel folks as a travel clinic. So things that we need to talk about based on where these patients are going to go. Right? So just keep that in mind, especially when we're talking about rabies. This thing can affect a lot of folks. Anybody know what this is?
For rabies
Who?
vaccine?
Yeah, it says rabies vaccine on it. The reason why I asked the question is I didn't know. Until I started teaching this class, I didn't know what this was. I had to go find it. So what happens is the parks people throw these out into the woods to let animals eat this stuff because it prevents them from getting rabies. Okay? I thought that was a freaking awesome idea. Like, wow, that's great. Right? So that's what that is. Okay. Facts. Using not disease of rodents, what that means is small animals, they can still get it. The lack of them spreading it is very, very minimal because their metabolism is so fast and they're so small. The stuff usually gets to their brain, affects their neurologic system, kills it really fast. Generally, rodents are not a big deal there. It gives you one exception, groundhogs. Those things are really big and really fat, so that's why they survive a lot longer than the other type of rodents. Here's a whole bunch of other atypical animals that can be affected. Mongooses, some people keep them as pets, right? Same thing with ferrets, some people keep them as pets. And then you've got domestic farm animals. Right? So we are exposed to some of these animals that can harbor some of this stuff. Right? But understand, Latin America, Africa, Asia, large issues with rabies. Like the World Health Organization tries to, educate the world with rabies issues. Okay? The Rabies Day is 20th September every year. Okay? So this little poster has some pretty good information on there. Okay? So live other infected animals really spreads this thing. 90% of human cause are caused by dog bites. That's worldwide, not necessarily in the U.S. Okay, now cute, two little rabies animals. Okay, so if you look at this map, here it's telling you what animal basically causes the most rabies in those parts of the country. So remember, depending upon what part of the country you live in or work in, is what's going to be most common for you. Right? So on the West Coast it's a skunk, and the East Coast it's a raccoon. You're here in Texas, small group there are fox or skunks. So keep in mind, depending upon where you are, it causes these problems. Here's your Texas area. What do you think is down this road here?
Caves?
Caves, correct. Caves, that is that 35 corridor between San Antonio and Austin. You have that Bat Cave up there, you have the Bat Bridge up there, you've got natural caverns between here and Austin. And so there's a whole bunch of corridors for bats to hang out in. So you can see all those red spots. All those red spots are bats. There's a whole bunch of them over here in Houston, on the Houston area. This is standard of care. This is standard of care. If you are passed out, knocked out, got punched out, drunk, and you wake up and there's a bat in the room, I don't know what happened. Sounds like fun, but if you're out and there's a bat in the room, you don't know if you got bit, you will get prophylaxis treatment. Okay? You will get prophylaxis treatment because you don't know if you got bit. Some of these bats' bites are minuscule and you can't even see them. Okay? So the risk versus benefit is more so on getting prophylaxis treatment. That is the standard of care. Okay? This right here is supposed to show you that this guy's got a bite mark, but you can't even see on this picture. Okay? Not quite sure. Could have been a bat. I don't know. So the genus is Lassa virus. Right? Once that bite, once whatever infected animal bites you, okay, it lights the peripheral nerves. So it's going to propagate where it bit you or where you got infected, and it'll propagate there, and then it'll start moving towards your peripheral nerves and to your spinal cord. Okay? This is a neurological. And it likes to go to your brain. Spreads to your nervous system, you have your peripheral nerves, and then the other body parts. This thing is so smart that once it invades your neurologic system and gets to your brain, it starts controlling all the other parts of your body to make you go spastic, seizures, coma, a whole bunch of things. But remember, this is a living organism. Living organisms are made to procreate, propagate, and continue to live, right? That's what we all do. That's what we do too, right? So once this thing gets into your brain, it follows the efferent nerve out of your brain to your salivary glands, and it causes you to over salivate. Okay? So if you remember when you see those rabies people on TV and in the movies, oh my God, they're foaming at the mouth. That's what it is. Okay? This thing sends signals down to your salivary glands. It goes down your efferent nerve into your salivary gland. It causes you to hypersalivate, because as you hypersalivate, that's how you're spreading it out. You want to look for someone else to bite. It's your aggressive aspect of this thing, because you want to continue it to propagate. That's how smart this thing is. It's crazy. Okay? And then these things hide when they bite you, they propagate wherever they are, and they make their way to their peripheral nervous system. But what they do is they can change the protein layers on the outside of their cells so that our immune system can't attack them. And then ultimately our immune system realizes we have them, and then it tries to attack them, but at that point it's too late. It's already invaded our central nervous system and our brain. So, pretty smart, this thing. Okay. Incubation period in human beings can be as short as 5 days, can be as long as 7 years. That's crazy, right? That's a long freaking incubation time period. Right? Crazy. Now, biggest factors here, right? Quality of virus in the saliva. Was it drool or was it an actual bite? Okay. What kind of animal bit you? Obviously, the larger the animal, probably the deeper the wound, the more she received from that animal. Right? The big one to remember is the site of the bite. Site of the bite is key in this thing. Okay? The closer it is to your head, okay, the closer it is to your neck and your head, the faster this thing is going to kick in. Okay? If it's really close to your head or your neck, that 7-year-long incubation period is not going to happen. Okay? If it's in this area here, it's got complete access to your central nervous system, so you're going to get infected pretty quick. Okay? Okay? Incubation period, post-bite. Initially, you're asymptomatic, no issues, no problem. Okay? Not going to have any antibody response because your body hasn't done anything. It'll initially propagate at the area of inoculation where it bit you, but it'll grow there for a little bit, and as you said, it changes its protein, outside layers of its protein, so your immune system doesn't even recognize it. So it just hangs out there until it gets big enough that it makes its way to the peripheral nervous system, and then you start having some serious problems. Okay? Okay? You will have a slight prodrome in those areas. Virus here enters your central nervous system, duration anywhere from 2 to 10 days. You'll have your non-specific symptoms will be your malaise, your headaches, your chills, your anorexia, your fever, your pharyngitis. Okay? Pharyngitis because it's going to start spreading its way down to your salivary glands, which affect your throat. Okay? Paresthesia, pain, prickling, tingling, or itching sensation is your prodrome. That's what's going to occur where the inoculation site is. Because remember, when it first occurs, it's only going to propagate around that little area. That's it. It's only going to stay there until it gets enough that it's going to start going into your nervous system. Okay? So that's somewhat pathognomonic for rabies, even after it's started to affect your neurologic system. So acute-wise, we're going to talk about 2 different kinds of rabies. We've got furious rabies, and we've got what we call paralytic rabies or dumb rabies. Okay? So furious rabies, if you look at your signs and symptoms here, you've got aggression, hyperactivity, restlessness, depression, biting, confusion, hallucination. Those guys are going rabid. Those guys are going crazy, right? This is what you see on TV. These guys are the ones that are foaming at the mouth, spitting everywhere, right? Trying to bite you, like zombies. That's what these guys are. Hence the word furious rabies, okay? Which matches all of its signs and symptoms. Okay? This person will have hallucinations, but they'll be somewhat episodic. So they'll be lucid for like a minute, and then they'll go nuts, and then they'll be lucid again, and then they'll go nuts, and they'll be lucid again. Okay? These guys, you have to be very careful. Okay? These guys, you have to have strapped down. Okay? They may be triggered by visual, audio, or tactile stimuli. So we'll talk about that when we get to the other piece. So we'll talk about next. We'll talk about the paralytic rabies. Okay. So paralytic rabies or dumb rabies. If you look at the signs and symptoms, patient's relatively quiet, lethargic, muscle weakness, difficulty swallowing, difficulty speaking, lack of aggression. Completely 180-degree opposite of the other one. So you're either furious or you're just relaxed. Okay. Deal with the paralytic one is that it just completely affected your central nervous system pretty quick. in a different way. 90% of it is furious, 10% may present as paralytic. Okay? When it happens in animals, we call it apathetic rabies. Usually you'll see an animal just standing there, like not moving, with stuff coming out of his mouth, or just laying on the ground, not moving, with stuff coming out of his mouth. Okay? That'll be your paralytic type of rabies. Okay? So here's a whole bunch of other neurologic neurologic signs and symptoms. Okay? Delirium, restlessness. A lot of these are somewhat specific, right? Because you've got lacrimation here, you've got perspiration and drooling. Okay, you've got thrashing, aphasia, because you're not going to leave the top of there, you're grunting a lot. Salivation, usually it's hypersalivation. Okay? Now this bottom part here, both for hydrophobia and aerophobia, they're pretty mnemonic for this thing, right? So, as I said, this thing is really, really smart. So it wants to propagate out. Human body understands that when we see water, we're going to want to drink it. This thing is already in your brain. Whenever you see water, when you have this, that person tries to shy away from it, thinking that you're going to make it swallow it. What we don't want, what they don't want, is they don't want that hypersalivation to go back into their body, right? I want it out, I don't want it in. So they're going to shy away from the water. That's because they know they're going to drink, right? This thing already causes hyperspasming in the throat, so that you don't swallow that spit it out. Okay? So giving them water makes it even worse. Okay? The other aspect for aerophobia, granted, they're not afraid necessarily to fly, right? As much as it is, if you blow wind over them, their skin starts to spasm. Okay? Just what it does because of the neurologic effect of this thing. And usually about 80% of folks usually end up with hydrophobia. Usually about 80% of them end up with hydrophobia. Right? Okay. Otherwise, we continue to let this thing go. You end up in a coma. Begin within 10 days of onset. We've only had 3 known cases in the United States that have survived rabies without a vaccine. 3. In all our time that we've known this. 3. Otherwise, this is just a fatal disease. Okay, so what are we going to do? That RIF, that's a big one. That one just measures the levels of the rabies virus neutralizing antibodies in your system. Okay, so that one's very specific for rabies, but it's not positive in all cases. It's only giving you 50%. So it's not that great, but we can't necessarily determine that. Usually you'll do a combo of PCR and DFA. Serology is usually what you'll do, a combination of those. But I do want you to highlight that center part there that says direct fluorescent antibody test on nuchal skin biopsy. Okay? That's what I need you to highlight because that's the most reliable test of infection during the first week. Okay? That is the most reliable test of infection during the first week. Now what do you see? You will see eosinophilic cytoplasmic inclusion tests. That's what you're going to see. What do those things look like? They look like negron bodies. Okay? When you look at it on a microscope, it'll be negron bodies, but the term is supposed to be eosinophilic cytoplasmic inclusions. That's what you're going to see. Okay? You can do an RT-PCR. There's a defect. Usually when you do defect alone, status post, they'll run that with brain tissue post-mortem for definitive. So you have to be careful. And then you can always send off the saliva to see if it contains any virus. Okay? But if you do hear negri bodies anywhere, you need to associate that with rabies. Okay? And know that specific term, eosinophilic cytoplasmic inclusions. Okay? This is what a negri body looks like. That looks like a little, in this case, it's almost like an upside down triangle, but then it's got these little black spots in it. Okay. Children, when they modify this like that. Okay. Here's a bunch of differentials if you want to be smart, other possibilities that may look similar to rabies. So treatment, outcome results require the following. Look, I can't tell you for bites of any kind, aggressive wound cleansing, not just when they get to see you, but when it initially happens, because that's when the bulk of stuff is on here. So if I get bit, I need to go to the house, I need to flush and clean it out as best I can before I go to the emergency department. Okay? Because that initially wipes out all the biggest gunk from initial infection. And then when they get to you, you do the same. You do vigorous wound cleansing. Right? Solution to pollution dilution. Flush the hell out of it. Okay? Out of any of these wounds, you flush the hell out of it. Okay? Decreasing the possibility of its spread. Okay? That will be the first thing that you do. Okay? Then we have the passive and active immunizations. Remember passive, right? You'll give them immunoglobulin, right? You'll give them immunoglobulin, but understand that that only causes passive immunity. So that's only going to stop it for a little bit. That stuff usually wears off, and then I got to give them more. That doesn't help the body. I want the body to generate some stuff to protect itself. In which case, now I got to give them a vaccine. Okay, which are the two vaccines there at the bottom. All right, so I'm going to give them immunoglobulin, and I'm giving some vaccine. That's how I treat this stuff, right? Okay, I need you to know this slide. This is the actual treatment of what happens. Okay, so pre-exposure. This is before anything bad happens, right? Think about your vets, think about your civil affairs teams. Before they go out, if you know they're going to be exposed to these things because you're going someplace endemic, then go ahead and pre-treat them. Real simple. On day 0 and on day 7, you get their shot. Every 3 years, you will get a booster. All right? It can be sooner than that, depending upon the exposure that you're going to be in. But post-exposure is the important one. Post-exposure, for the first one, if you have not had the vaccine and you get bit, you're going to get 4 shots in different days. On day 0, on day 3, on day 7, and on day 14. That is for people who have not been vaccinated. For people who have been vaccinated, you're only going to get shots on day 0 and day 3. Okay? Because in all reality, you're just creating more of a booster effect because they already should have some of those fighting aspects in their body, right? Any questions on that? Okay, that's pre-exposure versus post-exposure, right? This is the immunoglobulin treatment, okay? 20 milligrams international units per kilogram. Most or all solution is infiltrated around the wound. If you don't put all the solution around the wound, then give them the difference into their buttocks, away from the area where you gave them their immunization. Away from the area that you gave them immunization. If you go beyond the 20 international units per kilogram, according to the CDC and World Health Organization, you may cause other side effects that may not be wanted when you go beyond that. So stick specifically to that dosing. Right? Now, there's a caveat. There's always caveats for certain things, right? So the CDC and the World Health Organization clearly state if someone has been treated for rabies vaccination, right? I got the vaccine. I do not need to get immunoglobulin. If I've been treated for vaccine, if I've been given rabies vaccine and I get bit, I do not get immunoglobulin. Do I understand that? Now, if I do not have the vaccine and I get bit, then I get both, the immunoglobulin and the vaccine. Okay? You don't want to do that. The immunoglobulin may blunt the reaction of someone who has already been vaccinated for rabies, which we don't want to do. So do not give them that. All right? There's some further thoughts, right? Wound cleansing, extremely critical, right? I'm telling you that, it's extremely critical. first thing you should do, both as a patient initial site and then when they come in and see you. Okay, boosters every 3 years for the CDC, right? Coloquin, so this is now you're starting to get into some pharmacology here, right? Here it's telling you that coloquin may decrease that antibody response. So if you're going somewhere that has both rabies and malaria, you will not treat with coloquin. Maybe it's like, hey, guess what? You're getting doxed, right? Same thing with corticosteroids, but that's for long cases where it blunts your immune system. Okay, vaccine, IgE. Okay, so do not give the vaccine and immunoglobulin in the same arm. Make sure you go to the opposite areas. Okay, you don't want to mix them. Okay, and there it's telling you the immunoglobulin is unnecessary for post-exposure for previously vaccinated people. That's what I just told you. All right. Here's other post-exposure thoughts. If you really need to, call a consultant. All right. If you do have an animal, usually they'll keep that animal for about 10 days to see if they're doing anything. One of the things that we generally forget to ask, hey, what's your tetanus prophylaxis like? Right? Because remember, if there's more than 5 years, then you just go ahead and give them another big T, little d, right? The booster. Okay. Usually we leave these things open. We do not close them. We just let them heal on their own. Keep an eye on them. Make sure that they don't get secondary infection. Extremely important is your HPI, okay? Specimen of the bite, circumstances that occurred, type of exposure. Was this a domesticated animal, not a domesticated animal? Did they have rabies vaccination or did they not have rabies vaccination? These are all questions that you're going to ask for HPI. So remember, HPI is key for all of ID, right? And then ultimately here they added the tetanus if you didn't ask during your initial HPI presentation. One of the last things that we'll talk about, if you're not aware, there are some countries that require them to hold your animal for a couple of days, i.e. 10 to 14 days, to make sure that they're not rabid, even though you have your rabies vaccination card. Okay? So Hawaii and England being two of those places. Keep that in mind. Okay? Anybody have any questions? All right, yes, sir.
Just a quick one. So if you had, this is like clinical, if you had a troop that they said they were going to go to Thailand and they wanted to see the monkeys or something like that, would that be an indication to give them like a prep kind of deal?
Okay, so if everybody didn't hear that, the question is, right, as part of what we do, vacation planning with some of the guys that come see you, right? It's like if we're going to Thailand and we know they're going to that monkey beach or that monkey temple, is that a main reason to give it to them? That would be a discussion that you have with your patient. That's where you do that risk versus benefit. Hey, this is what can happen. This is what I can offer you. You want to take it, right? Versus the possibility of what can happen. Okay? And that's where you have that adult educated conversation, whether they choose to get it or not. It's not for you to say, you need to get it. Okay? Same deal with any of the travel stuff. You're offering the service, but it's up to them, with your guidance and education, whether or not they decide to take it. Okay? Now, military-wise, usually higher headquarters will tell you, you will require X, Y, Z. And if that's the case, then that's what you're going to get. Okay? Because it's going to try to hopefully protect you from wherever you're going to be. All right? Questions? All right. Remember, no prions on the test. Okay? So one less thing you got to worry about. If you have any questions, please text me. Somebody